Hey guys, so welcome back. So in this part of the video on the pathogenesis of the restrictive lung disease as well as bronchiectasis, we have finished talking about the pathology of the pathogenesis of the restrictive lung disease. So in this part of the video, we'll be talking about the pathogenesis of the bronchiectasis. So this is actually an important concept here, and we'll be talking about this concept in order to understand the pathogenesis of the bronchiectasis. And let's get started with the definitions first. So bronchiectasis is basically a chronic permanent dilatation of the bronchi or bronchioles due to chronic infection which cause the destruction of the airway wall, and therefore I would like to say that this bronchiectasis disease is an irreversible disease because the destruction is so severe that it cannot repair itself. Okay, so normally in this bronchiectasis, obstruction and infection are present together. So that means that the infection, it can be either infection appears first and that causes pus formation and lead to obstruction caused by pus and inflammatory exudates, or it can even be in this way such that obstruction occurs first that leads to the stagnation, which eventually can cause the infection, inflammation, as well as destruction of the airway wall. Okay, so this is a fun fact, like in US the most common cause of bronchiectasis is cystic fibrosis, whereas in worldwide it is most common cause of bronchiectasis is TB, that is tuberculosis. So the pathogenesis of this thing is just very simple, as I have written here. So it's just a vicious cycle here, and just remember this: at the end of the day there would be infection which lead to inflammation cause local tissue destruction, and destruction which would eventually cause dilatation. However exudate also can cause obstruction, and this obstruction causes infection, so that this process will occur until destruction and dilatation continuously occurs. So eventually this will lead to the bronchiectasis. So whatever I've talked just now is here, that that is like a, just now I talked infection. So infection, it can be either infection occurs first or obstruction occurs first. So either way, okay, let's say we start with infection. So infection in the case of tuberculosis is going to be infection. So infection will lead to inflammation. Inflammation can lead to exudate as well as destruction. The effect of inflammation is always destruction. Okay, this is going to inflame the wall and all, and exudate is because of the pus formation and all. So this exudate will be causing obstruction. Destruction will eventually lead to dilatation. Dilatation is continuous dilatation is what going to lead to bronchiectasis, and this obstruction is again going to add into infection, and if again this infection going to lead to this obstruction, dilatation, eventually bronchiectasis. Okay, so this is actually a vicious cycle, so you have to take care about it when you find out at an early stage itself. So now first of all we're going to look into the pathogenesis of the bronchiectasis when there is an obstruction. Okay, obstruction first, not infection. Obstruction first due to chronic infection. First of all we'll go and see chronic infection first, which eventually lead to obstruction. For example, tuberculosis, or even when you have a immunoglobulin deficiency. So here I've drawn a diagram here. This is a normal bronchus, this part is a normal bronchus, this one is the dilated bronchus, and this one is actually showing you the destruction of the lining epithelium, muscle, and as well as cartilage. So this green color here is actually the one which is showing here the accumulation of the pus, exudate, and secretion. So just to simply add here some notes on the histology of these lungs, bronchus. So the bronchus, histological epithelial cells are also known as a pseudostratified columna, which is ciliated. Okay, and of course at this stage they still have muscle layer with certain layer of cartilage. Okay, so you have three layers: epithelium, that is pseudostratified ciliated columna, muscle, as well as cartilage. Okay, and all these things will actually get destroyed when there's a chronic infection. So we'll go and look into how it occurs. Okay, so with continuous infection there would be destruction of lining epithelium. muscle as well as the cartilage with dilatation of airway. So in the beginning, destruction is just on the inner side, okay? It's just on the inner side, and that inner epithelial lining will eventually become regenerated, and it will be okay. But when this infection becomes okay, when this infection becomes repeated, that is chronic, then the wall starts to get destroyed. So once the wall starts to get destroyed, the mucociliary system, like the just now I said the cilia, they are not working. So now the pus exudate and secretion starts to accumulate, which eventually causes obstruction. So whatever that has happening here is dilatation, destruction, and eventually lead to obstruction, and all these things will eventually lead to further dilatation. So that is for the pathogenesis due to chronic infection. Now we're going to look into pathogenesis due to obstruction. Okay, and this obstruction, it can be either tumor, foreign body, or mucus plug that is not removed properly. So the pathogenesis is it can be proximally located tumor that press on the airway, and this caused that part of the airway which is being supplied and obstructed now to develop stagnation. So mucociliary system cannot clear the mucus, so this mucus will get trapped here, and secondary infection will occur, and this secondary infection will eventually lead to obstruction, further infection. So based on these two things, you have to remember that bronchiectasis is always a secondary disease and not a primary one. So that means it always occurs after obstruction and infection. Okay, there is also another pathogenesis that I'm not going to talk here, that is also known as Cartagnes syndrome, Kartagner apostrophe S syndrome. So this is due to the cilia not working properly. So when the cilia is not beating properly, there is a inefficient mucociliary system. So the primary, which is this condition, is also known as a primary ciliary dyskinesia, and this means the mucus cannot go up, so it will eventually lead to obstruction and repeated infection, inflammation, as well as destruction, eventually leading to bronchiectasis. So in a patient with bronchiectasis, you will find several things, such as the clinical presentation is always they will produce pus. Okay, always have a pus because of chronic infection. So patient will throw out cup full of pus, which is always productive, putrid, and smelly expectoration. Okay, and when there is the damage is already penetrating into the blood vessels, and also that's when hemoptysis will occur. And you can also see some clubbing of fingers. Okay, some clubbing of fingers. And of course, when the infection is too severe, cor pulmonale also can occur, that is a right heart failure can also occur. Then this is basically due to pulmonary hypertension. So basically, how do you treat this thing is you, of course, if tuberculosis, usually you will get antibiotic for infection, or if it is just obstruction, you just get some bronchodilator, and if it is a tumor, you do some surgery to remove it, and you will be fine. So that's it. This disease, bronchiectasis, is actually an irreversible disease, so you must find out at an early stage before the disease does its very worst kind of effect. So you have to find it very early. Okay, that's all for this video. I hope you guys have done something new. So thank you guys.